disclosures. Let's see if I can operate this. And today can be interactive. If anybody out there has suggestions or things that I haven't thought of that we'd like to add, I'd like to build this as I go along. So our objectives are kind of outlined here, very kind of general, to identify the determinants of general care adherence in homeless populations and some potential enhancements to help improve care. Hopefully we can understand special considerations for MAT, for Matt in particular, in a homeless population. And I added a little bit at the end to understand medication considerations for homeless persons with substance abuse history. And this is, again, a place where we can hopefully build on medications and their uses outside of the normal indications, but we'll get to that at the end. So this slide is just kind of a brief definition of homelessness and a logistical breakdown of homelessness. The first paragraph talks about homelessness having a huge subpopulation of folks with mental illness, but even a bigger population with folks with substance abuse and or mental illness, dual diagnosis. Brief definition of homelessness, any individual without permanent housing, and you can read that, but basically anybody who doesn't have a place to stay on a regular basis, and that includes people that are in shelters and on the streets camping, but it also includes people that are doubled up, as we say, and that's couch surfing. Essentially, you're staying with friends, with family, and it's not permanent. It's you're bouncing around. And then homeless individuals who are incarcerated or have a hospital admission and then are discharged without stable housing are also considered homeless. So that's the kind of the catch-all of folks that I'm talking about. Sometimes there's people who are in transition, and a lot of what we're talking about doesn't apply to them. I'm talking about people who, for whatever reason, find themselves temporarily homeless, but have a lot of good coping skills, maybe not an underlying mental illness or substance abuse or significant health problems that eventually get back on their feet in a short period of time. And I do see some of those folks in clinic, people who have moved to Albuquerque from the reservation or rural areas just to find work. And within a few weeks, they find work and they get themselves on their feet in their house. Or another subset of folks are people who have good jobs and families and lost their housing because of extenuating circumstances, maybe a prolonged illness that left them with huge hospital bills. Those folks usually get back on their feet fairly quickly. So I'm talking about more of a chronic homeless population. Anyhow, moving right along. So the first objective is to talk about, as I have in parentheses here, is why a lot of these folks are considered difficult by most regular docs, including mid-levels. And then I'll talk about a little bit what I do to kind of counteract some of these determinants. So the first one would be inappropriate physician expectations. I know that all of us providers, and I put physician here, but this applies to anybody, social workers, case managers, behavioral health folks. But if you go in with the expectation that folks are going to be on time for their appointments, make their appointments, not show up just randomly, then you're kind of expecting stuff that's not in their worldview. And you're setting yourself up for disappointment as well as not providing them with the best of care. So sometimes we have to reevaluate our expectations to make sure that we can allow for their discrepancies. And most often it's with appointments, but it's also with picking up medications, navigating the healthcare system, navigating refills at the pharmacy. All this stuff can be problematic. Another determinant is negative interactions with authority figures, and that includes us as healthcare professionals. Oftentimes, these folks are not welcome in lobbies or waiting rooms of typical clinics. Most often their interaction with the healthcare system is in the emergency room where they're stigmatized. That's something we've talked a lot about, stigma, but and treated poorly. So they have a lot of history with negative interactions. And the way I combat that, and I'm sure a lot of us already do this, is just trying to win over their trust. And there's a lot of ways to do that. Just some examples would be to give them a warm environment in which to come, meaning a welcoming environment. Give them address whatever issue they have prominent in their mind. It's not always matches what we think is the most pressing issue, but things like a hangnail can be painful, a paronychia or something. Ingrown toenails are one that we see a lot that are painful, and that's something they want addressed immediately. Whereas we might think getting the Hep C cured or getting their opioid use disorder under control is more important. But if we address what their main concern is, it goes a lot further to gaining their trust. Of course, doing things like conveying a non-judgmental attitude and providing some free services and incentives is what we do in our clinic. Coffee, breakfasts, snacks. And then another thing we have is peers and patient advocates readily available. And that all those kind of help grease the wheels of their interaction, at least in the beginning with us. And then the last bullet point there is that alienation from the healthcare system, and it kind of goes hand in hand with the previous point. And I don't know if there's a huge, those 2 points go hand in hand in that, negative interactions lead to alienation. Folks often don't want to be where we're at. They come to us either because they're desperate or because they were court ordered, or a lot of case management and behavioral health folks services will require medical services. So just providing for that goes a long way. One of the things that we do is, for example, at our clinic, we'll provide transportation to referrals. If I make a referral to cardiology or for colonoscopy or for any other specialty, we provide transportation. And like I said, we have hotel vouchers for post-surgical or emergent needs, things like that. Anyway, moving right along. Again, feel free to chime in if anybody has any ideas of how we can improve any of these things. So some of the special considerations that we see are related to different issues. The first one is that I'd like to discuss is resource-related issues. The patients that I see on a regular basis lack transportation, lack healthcare coverage. Even if they are eligible for Medicaid or Medicare, they have a hard time finding getting coverage, just because that can be difficult to navigate. And then they have a lot of competing priorities. Healthcare is not often top on their list when you don't have a place to stay, or you're cold and you're hungry. You've got family members that you're worried about. So some of the things that I do to combat those, just going along the list here, lack of transportation, like I mentioned before, we provide as much transportation as we can, but we also do outreach to the shelters. We do outreach to some of the rehab programs, meaning that healthcare providers and case managers, we actually go out to where they're at their location. Other things that we do in terms of addressing transportation is we provide bus passes and or Uber rides or taxi cabs. And then we also help them access their 1-800 Medicare transportation or Medicaid transportation. Other things that we do, we make it we're a patient-centered medical home, so we try to cover everything, including case management, which will help with getting coverage, getting IDs, getting other things that are more important to our population. We partner with a lot of the health providers in town that are also treating homeless individuals, so that we kind of keep tabs on people as they bounce from healthcare to the homeless, to us, to St. Martin's. So these are just ways that we address their resources. Another thing regarding health insurance, we try to stay on top of the ever-changing formulary landscape, so that, because if you prescribe something and it requires a prior auth, they're probably not going to come back and get it, or they're not going to wait for that prior auth to go through. Okay, other issues are related to their interpersonal self-management skills. A lot of folks have a cognitive impairment for a variety of reasons, traumatic brain injury, untreated psychosis, a lot of folks have lack of education. Chronic stress can affect their interpersonal skills, sleep deprivation. And one thing that, you'll hear a lot is life's very difficult and already complex for them. So a lot of things that we do, in addition to, like I've mentioned before, the warm, trusting environment and helping to build trust, is have ready access to our social workers, and try to steer our treatments and our ongoing healthcare plans to address the complexity of their life. If they again are trying to struggle to find a place to sleep or find their next meal, healthcare is not always the high on their priority list. So we do things that are, some of the stuff that I'll do. I'll make the prescriptions as simple as possible, and usually I'll address one issue at a time, just so we don't load them up with too much stuff. Within clinical guidelines, we try to keep them as streamlined as possible. Once daily versus TID dosing. I'm trying to think what else. Addressing diabetes on one visit, addressing their hypertension in another visit. Just seeing them more frequently helps with a lot of these interpersonal and stress-related skills. A lot of issues are related to their shelter. Folks, they have to leave the shelter at 4 a.m. So they're out on the street from 4 a.m. until when they first come in to see us. A lot of times they're carrying most of the times they're carrying all of their belongings with them. So medication storage is a problem. Medication safety is a problem if you're prescribing things that have street value. All of these things have to be taken into consideration. So I always consider, like I said, frequency, storage. We try to provide storage for medications that need to be refrigerated, or to give an example, Hep C medication usually comes in 4-week batches. So we will store all but 1 week for them, or whatever they need, all but 1 day if they want to come in every day for that. I try to fill prescriptions at the time of the visit at our pharmacy or at a close pharmacy, so that they don't have to go all over town. And of course, like I mentioned before, we simplify the medication regimens as much as we can to fit guidelines. There's a lot of combination medications to reduce pill burden, etc. And then lastly, on the medication topic is you really have to take into consideration side effects. Negative side effects can keep them from wanting to continue their medications. And by negative side effects, I'm talking about medications that are sedating. A lot of folks don't want to be put in a vulnerable situation in a violent kind of lifestyle if they're out on the streets. You don't want to give them something that's going to cause nausea or diarrhea. If they're going to be on the bus or they'll be out on the streets. So just side effects have to be really taken into consideration. Lifestyle related. Most of these folks are leading a very nomadic lifestyle, as I mentioned before, carrying all of their belongings with them all the time. Frequent incarcerations and hospitalizations, both at psych units and just regular hospitalizations, can lead them to not follow through with appointments, lead them not pick up prescriptions. They can disappear for long periods of time. So with that, I have to, and I would suggest if anybody has problems with this, you have to kind of reframe your policies on missed appointments, on, especially with MAT and controlled substance. Missed appointments is a sign of aberrant behavior. So we just have to be a little more flexible sometimes. We still want to make sure that we're checking for suspected misuse, but if somebody's incarcerated or hospitalized, usually there's some sort of way we can look that up As far as the nomadic lifestyle, the PMP is great. Sometimes folks will disappear from my clinic for a month, 2 months at a time, but I can check the PMP and see that they were down in Roswell and getting their Suboxone down there. So that's another resource that I use. And then a big one is trying to get at their first visit an update at every subsequent visit at emergency contacts, so that when these people do disappear, we can try to track them down. Most people will have a family member, even if it's out of state, that can get a hold of them. And this is particularly important for all medical care, but you know, a lot of these folks we're treating not just the Suboxone, but a lot of infectious disease that requires good compliance, so we have to reach them. And then this goes without saying per se, but the statistic from the NHCHC was kind of alarming to me. Young women without homes are much more likely to die prematurely than other women. So you just have to have that always on your radar and have a high index of suspicion for sexual abuse. We screen all the time for sexually transmitted infections and pregnancy. In my particular clinic, we also are aligned with the cities and the counties' sex trafficking programs. So we're constantly, on guard and looking for signs of a person being either trafficked or abused in other ways. So that's kind of obvious, but it's really big in our population. So it bears saying. And I mentioned this before, but mental illness and cognitive problems go hand in hand with homelessness. Here's a 50% statistic, but I would guess it's much higher. Cognitive problems from chronically untreated mental illness is big. Traumatic brain injuries, lifelong learning disabilities. There's a lot of things that can contribute to cognitive problems. So we have to make a lot of allowances and helping people navigate both our clinic, the system, medications. We've adjusted all of our education to kind of match people's levels of understanding. So I guess this segues into our third objective, and this is the one where if anybody wants to pitch in, this is a list of medications. This is my ever-growing list of medications that we typically are very common, and some of them you guys know are abused, but they're showing up, and I learn a lot of this from my patients who are just being honest with me. But here's a list of medications that we don't typically think of being misused, but they can be used as an adjunct in with other illegal or illicit substances for nefarious reasons. So you can take a look. Albuterol apparently enhances the effects of crack cocaine, which who knew? You take a puff and then you take a shot of albuterol, and it I guess enhances it. Clonidine. I was told by folks coming out of prison, I guess this is a big one in prison, they'll get clonidine and it prolongs the effects of heroin. Wellbutrin is being used a lot now in order to get high. And feel free to comment if anybody knows of any more. Pseudoephedrine, I think we all know, is used to make meth. Promethazine, which is given out a lot in emergency rooms, also enhances euphoria from opioids, including heroin and others. And as we know, can alleviate withdrawal symptoms, so it has a street value for that. Seroquel enhances the effects of heroin. Gabapentin is now used to produce a high, just like the Wellbutrin. It gets snorted or injected. And I didn't include all of the other medications on that list, but muscle relaxants, the tricyclics in particular, are being used now to get high. I don't know if you guys knew that. And then the last two are statins and other drugs metabolized in the liver. We have such a huge overlap with Hep C, some Hep B, but mostly Hep C and long-term alcohol abuse, that liver problems are very, very common. So we try to really monitor the drugs that are metabolized in the liver, and then statins, just closely watch them. And that's that. Here's some resources for folks who are working with folks with homelessness or find themselves needing to reach out. Maybe just pull this slide up. And these have a lot of just varied resources of both local and national programs to help folks. A lot of these will hyperlink to a local community resource, so they can be helpful there. And I guess that's it. Kind of a sparse presentation, but hopefully it helps with some considerations. And I guess we can open it up